Hello friends, on the suggestion of a student, I am recording this video. Rather, I will be recording different videos on the topic, the physiologic basis of diuretic action. I'm going to divide it into parts because there are lots of diuretic categories and therefore the video would be much longer. And therefore, today in this video, we will be describing one particular category, and that is carbonic anhydrase inhibitors, and the prototype being the acetazolamide, and the physiologic basis of its action as a diuretic. Well, let's start from the basics. But before that, I intend to discuss only the physiology behind these actions rather than the pharmacological part. So let that be clear at the outset. So focus will be on the physiology of reabsorption of the bicarbonates and how it is blocked by these categories, or in other cases like the NKCC transporter, NCC transporter, etc. So with that in mind, let's start. Starting with the basics, what are diuretics and why are they used? Well, diuretics are the drugs that increase the urine output by increasing the water content of the urine. So that's the general definition about a diuretic. When are they required? In what conditions? Well, they are required in the conditions where there is either fluid retention in the body, edematous states. So diuretics will increase the urine output, remove some body fluid, and thereby provide relief. Or the other conditions like hypertension or CCF, heart sometimes is, let's say in the conditions of heart failure, heart is failing as a pump and is unable to deal with that much amount of blood volume. So there the diuretics, by decreasing the circulating blood volume, will provide some relief. So that's the basic information about the diuretics. Before we proceed, let me also tell you that many of these categories, they are also natriuretics. That is, they cause natriuresis, that is loss of sodium into the urine and thereby loss of water into the urine. But the others are not natriuretic agents. In fact, a recent category of drugs that they have invented called aquauretics. Instead of diuresis, they are being called aquauretics. That is, they do not cause natriuresis, just cause water loss. Aquauresis, water loss into the urine. So that's one part. Then there are categories like this, carbonic anhydrase inhibitors or osmotic diuresis. They work independent of that action of natriuresis. So that's a basic information about the categories of drugs. Right. Now, basically in this video, we will be discussing this category, the carbonic anhydrase inhibitors, the drug being the acetazolamide, and where does it act in the kidney? How does it prevent the reabsorption of bicarbonate? Our entire focus will be on reabsorption of the bicarbonate. And then mechanism of action of the acetazolamide, its uses and toxicity, but not the pharmacology part, but the physiological basis behind these actions and uses, etc. So let's start. Now the first things first, as I mentioned, many of the diuretics, they are also natriuretics. They cause natriuresis and diuresis. That is, they prevent the sodium reabsorption. So sodium is lost into the urine and therefore water is also lost into the urine. What happens is, in this case, in the case of carbonic anhydrase inhibitors, they are not causing natriuresis per se. That's not their main action, but they are causing loss of bicarbonate mainly into the urine. Let's see and talk about the reabsorption of bicarbonate. That is where the whole game lies in the case of these drugs, this category. So there is a filtered bicarbonate at the glomerulus. And just to add some extra tinge of physiology, how much is the total daily filtered bicarbonate? It's calculated like this. px into GFR. Px is the plasma concentration of the substance, in this case the bicarbonate, into GFR. So plasma level of bicarbonate is 24 milliequivalents per liter and GFR is 180 liters per day, and therefore 24 into 180, 4320 milliequivalents of bicarbonate are reabsorbed per day. Just correction over here. This much is the total bicarbonate reabsorption every day. 90% or even more than 90% of the bicarbonate which got filtered is reabsorbed from the PCT, and the rest is reabsorbed in the other segments of the nephron. So major bulk of it is going to be reabsorbed from the PCT, and that is where the action occurs in the case of carbonic anhydrase inhibitors. Before we proceed further, let me just add one more tinge of physiology in this. Look, from the PCT, almost 2/3 of the filtered sodium and sodium chloride is reabsorbed, and filtered water. 67% or 2/3 of the filtered sodium chloride is also reabsorbed from the PCT, and 90% of the bicarbonate or sodium bicarbonate is also reabsorbed from the PCT. So that's quite a bulk of reabsorption. We would have liked to have a drug which stops the reabsorption of sodium chloride from the PCT. Look, we have two subjects of interest for the diuretic action. You know, in the criminology this term is used, the subject of interest. So here we have two subjects of interest which could have been used for diuretic action. One is sodium chloride. 67% of the sodium chloride reabsorption is taking place in the PCT. So if we would have liked a drug which blocks the reabsorption of sodium chloride from the PCT, because it's a major chunk. But at present there is no such drug that can block the sodium chloride reabsorption from the PCT. What we have is the carbonic anhydrase inhibitors which block the reabsorption of bicarbonate or sodium bicarbonate from the PCT. So that's the first point to be recognized, that bicarbonate reabsorption or sodium bicarbonate reabsorption will be stopped in the PCT, will be blocked in the PCT, so that the bicarbonate and along with that sodium and some amount of chloride and water will be lost into the urine as a result of blockade of the sodium bicarbonate reabsorption from the PCT. So that's the point number one, that the bicarbonate will flow all the way in the distal parts of the nephron. At other segments, there are some carbonic anhydrase independent mechanisms of bicarbonate reabsorption. So some amount of bicarbonate may get reabsorbed in the later segments, but all in all, as a net result, about 50% of the bicarbonate remains unreabsorbed. I mean, it will not be reabsorbed and will be excreted into the urine. Under normal conditions, 90% is getting reabsorbed here and almost all of it in the other segments. But when you use carbonic anhydrase inhibitors, almost 50% will be not reabsorbed from any of these segments and will be lost into the urine. Along with that, the water will be lost, and that's how the diuretic action will work. Now coming to the main part of this discussion. How does bicarbonate reabsorption occur from the PCT and how does the drug work? All right. So this is a representative diagram that the bicarbonate has been filtered, and I told you about 4320 milliequivalents of bicarbonate filtered every day. It starts flowing down the PCT. A very important point is to be highlighted here. That is, bicarbonate is in ionic form, and you know that the ionic forms are less diffusible. Non-ionic forms are more diffusible. So, reabsorption of this bicarbonate would not be easy, because the bicarbonate being ionic and therefore less diffusible, it cannot be easily reabsorbed like that. And therefore, the first event in this entire process is that this bicarbonate should be somehow converted into the non-ionic form. How does that happen? The first step is secretion of H plus in the same segment. This is the initial segment of the PCT. So here, these are the lining cells that you can see. The lumen, the lining cells, and then the blood vessel. Here, the lining cell, of course, has the apical membrane and the basolateral membrane. Apical membrane facing the lumen, basolateral side facing the blood vessel, interstitium and the blood vessel. So in the apical membrane, we have a transporter which is called as NHE3. NHE stands for sodium hydrogen exchanger. NHE. Sodium hydrogen exchanger. What it does is that it will remove the sodium from the lumen, and in exchange for that it will secrete the H plus into the lumen. As I mentioned, this bicarbonate has to be converted into some non-ionic form, only then it will be easily diffusible. So for that purpose, our starting point is that this NHE will secrete the H plus into the lumen so that it can bind with the bicarbonate, and the sodium has been removed. So sodium from the tubular fluids from the lumen is going to be reabsorbed as well in the PCT. Sodium came into the cell. Now everywhere in the nephron, there are on the basolateral side, there is sodium potassium pump. What this pump does is that it removes the sodium from inside the cell and sends it into the out of the cell into the interstitium and eventually into the blood vessel. So sodium transport is occurring like this. The NHE will remove the sodium from the tubular fluids and transports it into the cell, and in exchange the H plus is secreted. All right, the sodium which came into the cell will be then removed from the cell by the sodium potassium pump, and it will be taken into the blood. Now main focus is on this side. This H plus which was secreted will combine with the HCO3 minus bicarbonate to form H2CO3, and this will split into CO2 and H2O. So how was this possible? Well, there is an enzyme which is what we are mentioning, the carbonic anhydrase enzyme. Let's write it here. Carbonic anhydrase enzyme. You know what is so unique about this enzyme? It is a membrane bound enzyme, as well as it is present intracellularly in the cytoplasm. So here you can see that there are GPI linkages on the brush border of this cell, and this enzyme is linked to the membrane by these GPI linkages. So the carbonic anhydrase enzyme will act in this reaction, formation of H2CO3, which is going to split into CO2 and H2O. Now the CO2 will be entering the cell. CO2 being in the non-ionic form, CO2 being more diffusible, is now going to enter the cell easily. It is removed, it is separated from the H2O. That means it is dehydrated. That is where anhydrase, carbonic anhydrase. So CO2 dehydrated it enters the cell and it again is rehydrated inside the cell. That is again CO2 plus H2O converting into H2CO3. Let's write it here, H2CO3, which will again split into H plus and HCO3 minus. Okay, so again we have H plus and HCO3 minus inside the cell. And this was possible inside the cell because the carbonic anhydrase enzyme is very much present inside the cell as well. Okay, it was bound to this GPI linkages, it is bound to the membrane, so it could form this reaction in the tubular fluids and again inside the cell. Right, now this H plus is again ready to be exchanged. Remember we talked about the NHE, sodium hydrogen exchanger. So this H plus which is formed inside the cell will be now again transported back into the lumen for further bicarbonate reabsorption, and this HCO3 minus bicarbonate which is generated here inside the cell will be now transported independently into the interstitium. So it is moving this side, H plus is going to the other side. Bicarbonate will finally, let's write it here, bicarbonate via its transporter, it can be transported out of the cell across the basolateral membrane into the interstitium and then eventually into the bloodstream. So this is how bicarbonate is reabsorbed, and this is where carbonic anhydrase inhibitors will act. Carbonic anhydrase enzyme blockers, we are now talking about the diuretics. Carbonic anhydrase inhibitors, the prototype being acetazolamide, will inhibit this enzyme over here in the renal tubule, in the PCT, so that these reactions are not catalyzed, and that means bicarbonate which was filtered, which was coming by glomerular filtration, will not be reabsorbed, and this bicarbonate will move further. It will reach the distal segments of the nephron and eventually will be lost into the urine. And with bicarbonate or with the loss of sodium bicarbonate, there will be also loss of water, and that is how the carbonic anhydrase enzyme, carbonic anhydrase inhibitors work. That they don't allow the bicarbonate reabsorption. It is lost into the urine. Water is lost into the urine. But this is a very weak action. I mean, therefore, the acetazolamide is said to be a weak diuretic because it does not increase water output into the urine that much. So nowadays it's not used as a main primary diuretic for the serious conditions like heart failure or edematous conditions. So therefore then the question is, what is it used for? Acetazolamide or carbonic anhydrase inhibitors are used for some other conditions. I will focus on the two which involve some physiology. So acetazolamide is used in glaucoma, because glaucoma is with increased intraocular pressure. And how the acetazolamide can work here is that, you know, normally physiologically the ciliary body secretes bicarbonate into the aqueous humor. From the blood into the aqueous humor, the ciliary body secretes bicarbonate. So if this bicarbonate secretion is blocked over there, aqueous humor formation will be decreased, and thereby the intraocular pressure can decrease. So it's useful in glaucoma and acute mountain sickness. You know, in acute mountain sickness or as a preventive measure, acetazolamide is given. Why is that? Because again, the basis is similar, that CSF is secreted, or rather bicarbonate is secreted into the CSF by the choroid plexus, and that increases the volume of the CSF little bit. So if this bicarbonate secretion into the CSF is blocked, then CSF volume will reduce somehow, or a little bit, not somehow, but it will decrease, and plus there will be alteration in the pH of the CSF. This is known to prevent acute mountain sickness or will provide some relief in the acute mountain sickness. So I mean, the mountain sickness associated with the increased intracranial tension, nausea, vomiting, etc. And these drugs, they will decrease the CSF volume, thereby decrease the intracranial tension, and thereby they can provide the relief. Urinary alkalinization, that's quite obvious because bicarbonate is being lost into the urine. So obviously urine will be alkalinized. So whenever that's required, or for example metabolic alkalosis, metabolic alkalosis or even respiratory alkalosis for that matter, it's alkalosis, so alkalis need to be excreted into the urine and thereby provide the relief. So even here excess alkalis will be lost into the urine because bicarbonate, which is an alkali, its reabsorption will be blocked by the acetazolamide. Okay, so that is where it will be helpful. Toxicity, well, you can discuss it more in the pharmacology part, but hyperchloremic metabolic acidosis, obviously that's needless to say. If a lot of alkalis are lost into the urine by the action of acetazolamide, then the resultant condition will be acidosis. Renal stones, yes, by the action of these drugs, there is increased calcium excretion into the urine, and at the same time they decrease the excretion of solubilizing agents into the urine. Therefore what happens is calcium will become insoluble and will form the stones. So that's the basis for formation of renal stones, and that's the category number 1 that we discussed today, the carbonic anhydrase inhibitors. Next video we will discuss some other diuretics and their physiologic basis.